that are packed in the bone should be, let's say, roughly 20. 20. Let's say if you are having 20. If you deviate from it below, not above, if you deviate from it and you're above, then it means yours even do have excessive amount of minerals. But if you deviate from it by having anything below a standard deviation, or even a standard deviation of 2.5 from the mean given to individuals who come from the same ethnicity, who are females, who are like around the same age, we know that they are supposed to have 20, and you are having a figure that deviates from the mean of 20 by below 2.5 standard deviations, then we say that you are having osteoporosis. We will not wait for the fractures to happen before we say that you are having osteoporosis. Having that deviation from the mean known according to these parameters, your age, your ethnicity, and your sex, is enough for us to confirm. So basically, if you are using the cortical bone or the trabecular bone, we know that roughly for cortical bone, the bone mineral density is normally between 1,800 to 2,000 kg per meter cube, whilst for trabecular bones, the bone mineral density is between 80 to 580. So then, what are cortical bones? What are trabecular bones? We need to understand this. So now, before we go on, let's look at certain conditions. Excuse me. Let's look at briefly, we'll come back to the genetics and all those things. But before somebody will develop osteoporosis and associated fractures, it actually comes as a result of multiple factors. Some of them are genetic in nature. For example, the genes that code for collagen. Collagen is part of the bone. Roughly 25% of bone is collagen, which confers tensile strength to the bone. So if you are not having this and you are not developing proper collagen, that could be a problem. If you live and have an healthy bone lifestyle, you are the type who smoke, your diet doesn't contain enough calcium and other issues that can predispose you. Then other skeletal factors that can also lead to compromised bone strength. Some people can have issues like ricket, osteomalacia, and the bone becomes very soft. Ricket, you don't have enough vitamin D, and that can lead to a very soft bone. All of these can lead to osteoporosis. And of course, if this comes together with factors that increases somebody's chances of falling, for example, you have balance disorders, movement disorders, Parkinsonism, and other things. Once you are having osteoporosis and these problems are also there, the moment you fall, then you get fractures. Now, what is then trabecular bone? What is then cortical bone? And what is the composition of the bone itself? When we say trabecular bones, it is also known as the cancellous bones. So if you have ever chewed the legs of chicken before, you realize that at the extremities, you have some spongy-like structures there that you can easily chew. So those ends are what we call the trabecular bones. Softer than the middle. You can easily chew and it's very tasty. That is where you have higher turnover or bone remodeling. Turnout is very high there. There is more growth. But when you talk about the cortical bone, at that place you have excessive amount of calcium and phosphorus there, and this confers hardness to the bone. So the middle, in between the two extremities, you realize that that middle part is very, very hard, and this is the place that we call cortical bone. So the extremities that are soft is termed as the trabecular bone. The middle portion that is very hard, not easy to chew, is the cortical bone. In general, bone is a combination of so many things, a matrix of water and collagen plus the ions. So basically, collagen and water constitutes roughly 25% each. And of course, collagen confers tensile strength. It doesn't make the bone break easily, like elastic rheumatoid function kind of. Then the hardness is produced by the crystals, mainly calcium and phosphorus. That is 50% of the bone. And therefore, anything that happens to a reduction in calcium or phosphorus or collagen production could create a problem within the bone. Now, it is very important that we understand and know the number of cells that normally have any issue with the bone, where they are found, and the roles that they play. Because in osteoporosis, it is important to understand this because you may have some of the cells that contribute to the osteoporosis. For example, osteoclasts that normally degrade the bone versus osteoblasts that helps in bone formation. And therefore, let's look at these basic cells that are found. So they are called bone cells, basically four main types of bone cells. So the first one are the osteogenic cell, osteogenic bone cells. Interestingly, these are the only cells that divide. These are the only bone cells that undergoes mitosis, and they are located within deeper layers of the periosteum and the bone matrix. So the bone matrix is normally between the cells. Bone matrix is normally between the cells. So what is the periosteum? Periosteum is simply a membrane of blood vessels and nerves that wraps around the bone. So those nerves and blood vessels that are around the bone, you have osteogenic cells there. And you also have osteogenic cells within the bone matrix itself. These cells will produce or give birth to osteoblasts. So osteoblasts are produced from osteogenic cells. Then what will the osteoblasts do and what are they? These contains one nucleus. The osteoblast contains one nucleus and therefore they are termed mononucleated. And they are the cells that forms bones. So bone formation is all about osteoblasts that are produced from osteogenic cells. They are also located within that network of blood vessels and nerves that wraps around the bone, that is the periosteum. Then we have osteocytes. Osteocytes is just osteoblasts, the matured ones that are formed when they are trapped within the ions, that is calcium, and the bone matrix. Then you call them osteocytes. Then the bad guys, osteoclasts. Osteoclasts. These contains multiple nucleus and therefore they are multinucleated. And these are produced from white blood cells, monocytes, and macrophages. And therefore, it's not surprising that they destroy the bone. So they cause bone resorption. Whilst the first three are trying to produce the bone, especially osteoblasts. Osteoclasts will act in the opposite direction by causing bone degradation, also known as bone resorption. So in osteoporosis, one of the possible mechanisms could be that you have an increase or exaggerated osteoclast activity to cause bone resorption. Or you could also have reduced osteoblast activity such that the osteoclastic effect overwhelms that of the osteoblast. These are possible pathways through which osteoporosis can occur, because these ones will degrade the bone and release the ions into the bloodstream. While this one makes sure that you pack the ions into bone formation. And therefore, whenever the activity of the osteoclast overwhelms that of the osteoblast, then that will lead to osteoporosis. Any queries? Class captain.
No, please.
All right. Any other person with any concern? If not, then let's look at the types of osteoporosis. Basically, we have two main types, primary and secondary. And the primary have subtypes 1 and 2. And because of this, at times we classify the secondary one as type 3. Basically, it is primary and secondary. And the primary one will have two subtypes. So what are these types? So the primary subtype 1 is also termed postmenopausal osteoporosis. So obviously, this happens especially in women after menopause. And typical of them, 5 to 20% may suffer from this type of osteoporosis. To 20 years menopause, they may get beneficial effect when it comes to bone formation. Estrogen, for example, can increase osteoblastic activity whilst minimizing osteoclast activity. Once you don't have estrogen, then this benefit is lost, and therefore you have a high risk of bone resorption. Men too, when they grow, then they also, because remember, men, we also produce some level of estrogen. Our main sex hormone is testosterone, but don't forget, men also produce estrogen. That is why if you have some man with excessive production, then that man will exhibit feminine behavior. So it can also happen in men, but females actually have excessive estrogen and they benefit from that more as compared to their male counterparts. And therefore, when they lose the estrogen, it puts them at a higher risk as compared to their male counterparts. So females, they have about 8 times chance of getting this condition as compared to their male counterparts. So here again, we are having females being at a higher risk. In osteoarthritis, it is females. In rheumatoid arthritis, females. In osteoporosis, females. It is only in gouty arthritis that male gender becomes a higher risk as compared to female gender. So do not forget, only gouty arthritis, men will be at a higher risk. All the others, rheumatoid, osteoarthritis, osteoporosis, females are always at a higher risk. Yes, so you can see that if you have decreased estrogen, then you have increased sensitivity of bone to parathyroid hormone. What happens? The parathyroid hormone will activate osteoclastic activity, and therefore you are going to have excessive bone resorption, confirming why women are always at an increased risk as compared to their male counterparts. So how about the primary type 2? The primary type 2 is also known as senile osteoporosis. So senile, everything about senile means that it happens in old age, elderly. So you are very old, then it is termed type 2 or senile type of osteoporosis. And therefore it occurs in the elderly, those above 70 years. We all know the input of aging when it comes to so many types of conditions. Of course, when you are aging, then all your organ functions will be going down. And therefore, even if you don't fall sick, the age alone will eventually kill you. For example, we are talking about kidney function, renal function. It includes calcitriol production. With age, you get renal impairment, you get reduced amount of calcitriol. Obviously, one will need calcitriol for effective GI calcium absorption. And if you have reduced renal function as a result of aging, you also have reduced calcitriol. This will reduce your ability to absorb calcium from the GIT. No calcium in the blood, where are you going to get calcium into bones? You rather go into your bones, break them down so that you don't suffer from hypocalcemia. So this, as you learned from your renals, it can cause secondary hyperparathyroidism. Renal problems will lead to secondary hyperparathyroidism. And one of the problems is increased sensitivity of the bone to osteoclast. Osteoclast will always cause bone resorption to get some calcium into the blood to avoid hypocalcemia, and this will lead to osteoporosis. So age alone can also cause type 2 of the primary type of osteoporosis. And now let's look at the secondary, which is also known as type 3. So when we say secondary in terms of conditions, a condition is secondary to something, then it means there is an underlying cause, either another condition or there is a factor that is obviously contributing to osteoporosis. So secondary osteoporosis, for example, we all know that there should be an underlying cause, and this may include issues like renal failure. That is when you are still young. You are not talking about when you are old and your age alone gives you renal impairment. This time it's occurring at even a younger age. You get renal failure, it can happen. If you get hormonal imbalances, several types of hormonal
Hello,
imbalances.
sir.
Yeah, hello?
Sorry,
Hello?
myself and the class. Yes, sir. Please, can you hear me?
Yeah.
Sorry, I have to take you back small. Please, where we are, we lost you briefly when you started the times.
Where
Our
you are?
networks. Yes,
Are
our
you
net,
and who?
myself and the class captain. We are the same place. The network, the two networks we have all went off
Okay, so at what point?
when you started with the types. So if you can briefly run us through.
Okay, so we have two main types. That is the primary and the secondary. But the primary one, we have two subtypes. That is type 1 and type 2. And at times, the secondary one is also termed the type 3. So the primary type 1 is the one that occurs in women after menopause. Normally, by 15 to 20 years after menopause, they get type of osteoporosis. Why? Because at that point, you are not having estrogen. And without estrogen, your body becomes more sensitive to parathyroid hormone. What happens if parathyroid hormone is released? It stimulates osteoclast, and osteoclast will cause bone resorption that will lead to osteoporosis. This type, we are saying it's more common in men. So why are we talking about men here whilst we are mentioning menopause? Remember, we also produce an amount of estrogen. That is how come if any man has high levels of estrogen, the person exhibits feminine features. But since we don't depend on estrogen, and it is women who always depend on estrogen for some of these benefits, when the estrogen is not there between the two sex, obviously the one who depend more on estrogen will suffer. And therefore, it's not surprising that women, the risk that they have for getting osteoporosis is about 8 times that of men. So when it comes to the primary type 1, it is also called postmenopausal osteoporosis. Women are at increased risk about 8 times of getting this condition or this type of osteoporosis as compared to their male counterpart. And the second one is type 2, also known as senile osteoporosis. So senile conditions like senile dementia is you are getting a problem because you are very old. So if you get any condition because of old age, then they qualify it with senile. So senile dementia, senile osteoporosis. So you can see that the age is when you are above 70 years. Aging alone decreases organ functions, including renal function. One of the functions of your kidneys is to produce calcitriol, which is vitamin D. What will calcitriol do? It improves GI calcium absorption. And therefore, if you don't have enough calcitriol because you are aging and your kidney function is declining, you are going to have lesser and lesser calcium absorption. This leading to hypocalcemia will lead to secondary hyperparathyroidism. You learned this when you were doing kidneys, CKD, you learned it. And parathyroid hormone, when it is out, again, will stimulate your osteoclast, and that will lead to bone resorption. So if you get osteoporosis because of your age, then it is termed the primary type 2 or the senile type of osteoporosis. Then the type 3, which is also known as the secondary type of osteoporosis. This is caused by underlying effect or underlying factor. So whenever you see a condition is secondary to something, then it means there is an underlying cause that you can actually detect, and that will give rise to the condition. So this will happen when you are exposed to the underlying cause, be it a disease, be it your diet, be it some drugs. It depends. And therefore, this one, we don't have any differences between the two sexes. Men and women, all they have the same risk of getting this type of osteoporosis, and it covers about 40% of all osteoporosis cases. One could suffer from hormonal imbalances. For example, if you get Cushing's syndrome and you are producing excessive cortisol. Cortisol is very dangerous because it can reduce your osteoblastic activity whilst it increases your osteoclastic activities. So one of the key systemic side effects of corticosteroids or glucocorticoids, they say it is osteoporosis. Of course, this is how it happens. So hormonal imbalances, even hyperparathyroidism, which is another hormonal problem. You can get primary hyperparathyroidism. That is a primary problem with the parathyroid gland. You have a problem with the gland, and the gland is over-secreting. This will increase the activity of osteoclast, and you have a problem. Cortisol increase in Cushing's syndrome is another problem. Obviously, if you have renal failure, that will lead to secondary hyperparathyroidism and eventually osteoporosis. Yes, I've just mentioned hyperparathyroidism. Even hyperthyroidism, where you have increased activities, you even activate your metabolic enzymes, and therefore hormones like estrogen that are beneficial to the prevention of osteoporosis can be cleared easily. So you have estrogen quickly being cleared, you have vitamin D quickly being metabolized, and all of this will predispose you to osteoporosis. GI disorders that impair or minimize calcium absorption, that can also predispose individuals. Certain drugs If you are on glucocorticoid therapy, for example, you are having chronic inflammatory conditions like rheumatoid arthritis, and you are put on long-term use of glucocorticoids, which the guidelines doesn't favor, and you do it, for example, high dose more than 3 months or even all the way to 3 months, you can suffer from osteoporosis because glucocorticoids obviously would be converted to cortisol and you suffer. Some people also suffer from problems that they are born with. For example, osteogenesis imperfecta. This, when you are born with it results in decreased mineralization of your bone, and that could result in a problem. Inflammatory arthritis, like rheumatoid arthritis, remember that as part of the cytokines, it will cause tissues within the bone or the joint to produce proteolytic enzymes. Remember, your protein contains collagen, which is protein. Your bone contains collagen, which is protein in nature. So the proteolytic enzymes can destroy your bone. That is, the collagen within your bone could be destroyed in osteo or rheumatoid arthritis, and that can predispose you to osteoporosis. Poor nutrition, you don't eat enough calcium. Your diet doesn't contain enough calcium, or you eat other substances that are poisonous to the bone. All of these can predispose individuals to osteoporosis. And when it happens, as a result of some of these underlying causes, we say that you are having the secondary type of osteoporosis or the type 3 osteoporosis. Any questions? Any questions? Last captain, are you there?
Yes, please.
All right. Any issues so far?
Sir, please, I have a
Okay.
question.
All right.
Sorry, to the subtype 1. So, can we say that before menopause, men are at a higher risk, but after menopause, that's when women
No,
are at a higher risk?
no. The amount of estrogen that we have is enough for us. Is enough for us. So all through, regardless of age, women are always at an increased risk as compared to men. It's a condition where women are always, regardless of your age, at an increased risk. It becomes worse after menopause. Are you okay?
Yes, please. Thank you.
All right. All right. So again, let's look at risk factors. And of course, the risk factors are always going to, as in, consider the same, most of the secondary causes of osteoporosis. So we have some that are not modifiable and some that possibly we can modify. So let's look at some of them. Advanced age, you can modify. You can modify your female gender. Female sex cannot be modified. You can't also modify your ethnicity. So these are not modifiable. So as I said, female sex, you have enough estrogen that is helping you. When you hit menopause, or maybe you have a problem with your female genital organs and your reproductive system in general, and they take out your ovaries, then you are in trouble because your estrogen production is going to be reduced, and that is going to affect your bone mineral density. Yes. In males, yeah, we also have some levels of estrogen, which is augmented by testosterone, but we don't suffer too much from it. So when you have reduction in this, fine. As compared to the female counterparts, they will always suffer. Ethnicity, they say those with European ancestry or Asian ancestry, they have high risk of getting this type of problems, osteoporosis. Now, small stature. If you are born with a very small stature, you have tiny bones. Tiny bones can break easily as compared to somebody who has a wider frame, heavy bones. So when you are born with a small stature, you can also change it. It's just your genetics. Your bones are tiny and they can easily break with the slightest force or pressure applied. Family history, you can't change that. If in your family you guys do have low bone mineral density, then of course you can't go back and change your family history. Of course, we know that almost about 30 genes are involved when it comes to osteoporosis. And if you inherit any of this as part of your family history, then of course you can't do anything. If you also have your own, you have a history of osteoporotic fracture already, then that one too, you can't change it. You have suffered from it before and you stand at a higher chance of getting it again. So that one puts you at a risk of two times. You have two times chance of getting it as compared to somebody who has never suffered from any fracture. So all of these are non-modifiable. Your age, your sex, your ethnicity, small stature, family history, and your medical history of suffering from any form of fracture. These cannot be modified. Now let's look at some of the potentially modifiable risk factors. If you drink alcohol in excess, you can reduce it. We are not saying stop, but you can reduce it. So the same old cutoff point, do not take more than 2 units per day, which amount to 14 units per week. We have some people who drink a lot above 3 units per day. This will not help you because excessive alcohol with its metabolite will decrease osteoblasts, and therefore your bone formation is going to reduce. At the other end, you are increasing parathyroid and cortisol levels. Alcohol will increase that. That will lead to increased osteoclastic activation and you'll be in trouble. But always remember that small amount of alcohols do have beneficial effects. That is the findings. So that can even improve your bone mineral density. Small amount of alcohol leads to increase in bone mineral density. But when you take it in excess, that becomes poisonous. You take it in excess, it becomes poisonous. If you have vitamin D deficiency, then you are in trouble. Reduce vitamin D, reduce calcium absorption. This will activate your parathyroid gland and you secrete excessive parathyroid hormone. What happens? Osteoclast activation, increasing bone resorption. Those who smoke cigarette, nicotine, what will
Now, please have a
nicotine?
question.
All right.
And please, in terms of the alcohol consumption, in terms of the quantity, how much is the small?
Oh, we are talking about the normal range,
So the
14
less than
spread.
14 units a week.
Yes, you spread it up. If you can do up to 14, the cutoff point, fine. But always remember that once you are on alcohol, you are going to develop tolerance. And there is
Mm.
always that chance of you going overboard with time. Because the amount that you take versus the benefits that you get or the enjoyment or the response keeps on decreasing. And always there is that threat of you taking excess with time because of tolerance. And by all means, in the beginning, if you are within range, eventually you go overboard because you take alcohol like you are buying credit and you are not getting the feedback, you are not getting the response, you top up. So you eventually top up, and that will cause some of these problems. But if you're able to stay within range, within 14 units, if you spread it equally, that is 2 units per day, then that becomes beneficial. But there is always that tendency to go overboard when it comes to alcohol. Are you okay?
Yes, please. Thank you.
All right. Right. So those who smoke, nicotine is everywhere. It's always a bad guy. Almost all the conditions, nicotine is a bad guy. So they always say, cease smoking, stop. Alcohol, in some situations, they say reduce. Why? Because nicotine inhibits osteoblastic activity. Again, nicotine can speed up the breakdown or the metabolism of estrogen. You are going to have a reduced body weight. Remember, small stature is a risk factor. So that will also reduce your bone size. And in women who smoke, they tend to have menopause at early age, young age menopause, because it's going to reduce your estrogen production. So with all these bad effects, why can't you quit or cease smoking? Nicotine is a very bad agent. Those who have sedentary lifestyle or underweight, sedentary lifestyle in particular, if you have made this observation, when you get any fracture and they put you in POP, with that limited movement or limited activity, you realize that by the time they take off the POP, that leg will appear smaller than the other leg, because bone formation normally occurs with physical activity. Of course, any organ or any part of the body that doesn't work will atrophy. So it's not surprising that once you have limited activity in any bone, then that bone will also reduce in size. Once you have a reduction in size, small stature, remember, you can easily break it. So that becomes a risk factor for osteoporotic fractures. How you eat, your diet, you have to take a proper diet which will contain the recommended amount of all the nutrients that we always talk about, from amino acids here and electrolyte in particular. So if your diet contains low amount of calcium and phosphorus in particular, you could be in trouble. Some people also take excessive amount of sodium. That is very bad, because sodium can increase acidity and antagonize bone formation. So excessive inflammation that always results in decreasing pH is not good for bone health. It can lead to bone resorption. Again, malnutrition, you are not taking enough amino acids. How are you going to have protein synthesis? You need to feed the body with enough amino acids so that you can produce proteins. Don't forget that collagen, which is part of the bone, is made up of amino acids: proline, hydroxyproline, and glycine. These are the makeup of collagen. The growth factor or growth hormone that will help you to grow in size, including the bone, is a protein. If not glycoprotein, is a protein. So it contains protein. You need to feed the body with amino acids before. And remember, if you don't produce enough collagen, which confers tensile strength to the bone, your bone becomes brittle. It becomes pimping. It's not that, as in, it can't withstand pressure. And any form of stress, any form of pressure that falls on the bone, since the bone has become brittle, it can easily break. So diet is very important. Some people can also get poisons with heavy metals, so like cadmium. So if you are poisoned with heavy metals like cadmium, then this can also be associated with osteoporosis, because it degrades your bone mineral density, of course, which means you are going to get bone mineral demineralization. You lose calcium and phosphorus. Then these confer hardness to the bone. Your bone becomes very soft and can easily break. Immobilization, I've mentioned that one. Hypogonadal problems. So estrogen, testosterone, numerous effects of estrogen when it comes to bone strength and bone formation. So for example, if from hypogonadal problems you are having reduced amount of estrogen, look at the benefit of estrogen. So the direct effect of estrogen when it comes to bone is that it can increase osteoblastic activity. whilst decreasing osteoclastic activity. That is the end result of estrogen's effect. So you always need some estrogen and in men testosterone to a certain level to maintain a very good bone health. Then endocrine disorders. So Cushing syndrome, as I've said, will also lead to increasing osteoblastic effect. So if you have normal levels and it's not in excess, then osteoblasts will not suffer. The moment you have excessive cortisol, then you are going to decrease your amount of osteoblasts, whilst you increase the amount of osteoclast, you'll be in trouble. Hyperparathyroidism, we've been mentioning it. Thyrotoxicosis, this can increase your metabolic rate, you degrade some of them. Again, on its own, the T3 receptors on osteoclast and osteoblast will inhibit the activity of osteoblast whilst increasing the activity of osteoclast. In DM, a similar problem occurs. If you have adrenal insufficiency, you are going to be treated with glucocorticoids. And of course, that will present as if you are having Cushing's syndrome. In rheumatoid disorders, for example, like rheumatoid arthritis that we discussed the other day, you are going to have increasing proteolytic activity that can destroy your bone. Again, you might be on glucocorticoids for some time. That would also predispose you. So both the condition itself, the pathophysiology itself of the condition, plus the treatment modalities could expose you to osteoporosis. And these ones are modifiable because per the guidelines that we discussed last week on rheumatoid arthritis, as an example, there is a caution that because of some of these problems, do not overdo glucocorticoids. You use them as bridging therapies or agent to cover initially before the DMARDs actually take effect. So don't give these drugs to patients excessively over a very long time. Yes, medication. So steroids and all those things, you have to minimize their use. If somebody
Please, I have
is
a
having,
question.
all right.
And please, in terms of the DM and the thyrotoxicosis, please, what's the relationship between the DM and then the thyroid gland secreting higher levels
No,
of
no,
estrogen?
it's not thyroid, but you are going to have a similar problem where in DM you have a lot of mal uh, problems with almost every organ system. In DM, remember you could have inflammations. You get it, your immunity is down. Inflammation is everywhere. And this inflammation produces cytokines. You appreciate that in DM you can get inflammation.
Yes, please.
Yes. And this can be widespread and can affect the bone. So once you have inflammations, you are producing inflammatory cells, cytokines, proteolytic enzymes. You can connect. So you have a lot of problems.
Yes,
Are you
please.
okay? All right.
Yes, please. Thank you.
All right. So a lot of medications, steroids, we've mentioned steroids. If you have barbiturate, phenytoin, these are enzyme activated. They are enzyme inducers and therefore can accelerate, for example, the metabolism of this good guy, calcitriol. And you would have these drugs or these hormones being cleared easily. If they are cleared, you are not going to have enough calcium absorption. If somebody comes with hypothyroidism and you over replace and you cause drug-induced hyperthyroidism, you are increasing the person's chances of getting osteoporosis. T3 activation on osteoblast inhibit osteoblast, whilst T3 activation on osteoclast activate osteoclast. Again, in thyrotoxicosis, you have high metabolic rate, and therefore you can clear hormones such as estrogen and calcitriol easily. Somebody on PPI can interfere with calcium absorption from the GIT because of the reduced acidity. So these are examples of medications that can also contribute to high risk osteoporosis. Now, if you have osteoporosis, it doesn't mean that you are having fractures, but that predisposes you to fractures. And of course, before you get fractures, there are certain inputs that should occur before you get the fractures. Anything that puts pressure on the bone, because the bone is already weak, the slightest pressure or tension on the bone, then the fracture will come. So fall risk is very dangerous if you have osteoporosis, because the moment you fall, you are going to break a bone. The slightest fall, then the bone will break. Everybody will be surprised. But with this slight fall, the impact wasn't there. Just some slight fall. You even fell on a foam, yet you are having a fracture. So it is important that you look at the risk when it comes to falling. If somebody has any condition and collapse, of course, the person will fall. If there are issues like impaired eyesight, if you can't see well, it increases your chances of falling. If you have balance disorders, movement disorders such as Parkinsonism, or if you have sarcopenia, that is age-related loss of skeletal muscle, it affects your muscle strength, you can easily fall. So all of these are problems. And in osteoporosis, normally, of course, the fracture can occur at any place, but the person's spine, that is the vertebra and the hip, as well as the wrist, are almost always the type of bones that suffers from fracture. Fine, your skull and your facial bones can also suffer, but these areas are mostly at risk of fracture when the person falls. Okay, enough on all those things. What is the pathophysiology? Very simple. Bone is always undergoing remodeling. There is always bone formation and bone resorption. Bone formation, bone resorption. So there is always osteoclastic and osteoblastic activities going on. In osteoporosis, the basic problem is that you are having osteoclastic activity, that is bone resorption, not being able to match with bone production. That is the simple problem. And therefore, there is a deficit in either collagen or there is a deficit in the minerals that forms the bone. So simple mechanisms that can result in this, all in all, is when you have inadequate peak bone mass. Inadequate peak bone mass, all because osteoclastic activity has overwhelmed osteoblastic activity. And therefore, there will be excessive bone resorption. There will be excessive bone resorption, and that will lead to the problem of osteoporosis. If it happens, how do such individuals present? Because osteoporosis almost always goes with recurrent fractures. In most individuals, of course, considering the type of bones that normally suffer from fractures, especially your vertebra, in most people, they can get multiple fractures of the vertebra as an example. So typical of osteoporotic patients, because of the repeated or multiple fractures within the vertebra as an example, they may present with an overcurvature of the vertebra, especially the thoracic area. So it makes them appear shorter because the vertebra, when it's straight, you look normal on your back. The moment you bend it, then the person will appear shorter than. So you see this a lot in the elderly, where you see them having kyphosis. So this is kyphosis. The middle one, because of repeated fractures and remodeling, you see that the vertebra, when it is straight, you appear as in taller than when it will bend. So some people can get this outward curvature and they appear shorter than they used to. Or they can get an inward curvature. This player is a Sterling. Sterling is always having this type of problem. So that will make you appear shorter than you are. Or you can get a sideways curvature, that is scoliosis. So this is typical because of repeated vertebral fractures. It's either you are suffering from kyphosis, where you see them always bending downwards. This is very common in the elderly. Or you get lordosis, that is the inward curvature. Both will reduce your height as well as scoliosis. That one too. And of course, this will come with persistent pain. You are always in pain. And of course, with the existing pain, you dare not use that joint or use that bone. So you tend to try and not move a lot. So this leads to reduced movement. Remember, if you underuse that bone, it can also atrophy and further increase your chances of worsening the existing osteoporosis. But how do you do proper assessment and proper diagnosis? These are just presenting signs and symptoms, the pain and the reduction in height because of either kyphosis, scoliosis, or lordosis. But how do you objectively analyze and diagnose osteoporosis? So this, we are trying to adapt the recommendations by the American Association of Clinical Endocrinologists alongside American College of Endocrinology. This is coming from the 2020 guidelines. Any question before we start? Lance Captain, any questions so far before? Okay. Any other member of the class, do you have any questions before we start how to assess or evaluate osteoporosis, fracture risk, and the diagnosis of osteoporosis proper? So now, how do you approach it when it comes to the evaluation, assessment, diagnosis in general? So the guideline states that when it comes to post-menopausal women, they are age 50 or above, because they are in menopause, they are high-risk individuals. And of course, there is the need to assess all of them for the risk factors or the possibility of osteoporosis. They are high-risk individuals. So there is the need to always try.
For you. I should
Any
come.
chance? Hello?
Or who should come? You want part to come and wash it for you?
Please mute your mic. Hello? Okay. So now, these individuals, they should be our target because they are high risk. Now, how do you approach it? History is very important because looking at the various risk factors that we've discussed so far, drug history is very important, medical history, very important, family history, very important. And therefore, because this could be the underlying cause of osteoporosis. And therefore, if you don't take a very good history, how are you going to identify some of these problems? So history is very important, as well as physical examinations. You need to examine the patient. For example, the presence of these vertebral problems, lordosis, kyphosis, or whatever. Then objectively, you need to also assess what we called fracture risk. So we have assessment tools. We have calculators that can be used to predict the individual's risk, as in risk of getting fractures. So for example, you can use this tool called the fracture risk assessment tool. And the guideline says that this, of course, this is not the only assessment tool. If you have any other assessment tool, you can also use. So this is very, very important, the fracture risk assessment tool, to help you initially evaluate the person's chance of getting fractures from osteoporosis. The history can help you know some of the underlying causes. You'll know. Then physical examination will let you know some of the presenting signs. and even symptoms when it comes to osteoporosis. And on top of it, you do fracture risk assessment. Now, there is also the need to find out the person's bone mineral density, because the minerals gives you bone strength. Collagen gives you tensile strength. The hardness of the bone comes from the minerals. And therefore, the more you have minerals in the bone, the more your bone becomes very hard. The lesser the mineral density, the softer your bone, and the higher risk you have for fractures. So consider bone mineral density measurement. How do you do it? You use an axial dual energy X-ray absorptiometry. So what class captain, how many types of bones do we have in general? We have axial, skeleton, and what?
Mm,
In musculoskeletals, we have the skeleton types. We have the axial skeleton, which is the bones of the skull, your face, your ribs, your vertebra. Yeah, these are the axial skeleton. You have the axial skeleton, and what else? The appendicular skeleton. Am I right? Last captain.
yes, yes, you're right.
So the appendages constitute the appendicular skeleton, whilst your core body, the bones in there. So starting from your head, your vertebra, which joins the head, your facial muscles, the bones in the ears, and the rib cage. These are the axial, as in skeleton, and your fibula, your tibia, your those things, the appendages, bones of the appendages, constitute the appendicular skeleton. They are recommending that you do a measurement on the axials, normally the vertebra in particular. So you can use the vertebra, the bones in there, and you use this method called dual energy X-ray absorptiometry that can measure the bone mineral density within, for example, the vertebra. Then you compare it to the average. And if the person is deviating from the average as per the person's age, sex, and ethnicity, there is always an average for these factors. And if the person is deviating from the mean by below 2.5 or more, that is 2.6, 2 point whatever, 3, deviating negatively, then it is enough to, as in, conclude that the person is having osteoporosis, even without any fractures. So bone mineral density measurement alone can help you. So consider bone mineral density measurement using axial dual energy X-ray absorptiometry. Note that with this, history, physical examination, fracture risk, and dual energy X-ray absorptiometry, osteoporosis will be diagnosed if there is a presence of fractures, even in the absence of other metabolic bone disorders. Metabolic bone disorders have rickets, you can have osteomalacia, you can have whatever. So even with the absence of these conditions, you just clear them. They are not there, and the person is having fractures. Osteoporosis is diagnosed when there is fragility, fractures, when you don't have any of these metabolic abnormalities that can contribute to bone fractures, and even if the bone mineral density is normal. So that is the first criterion for diagnosing osteoporosis. Absence of other metabolic conditions that can give rise to bone fractures, but there is fractures. Then you can think about osteoporosis. So osteoporosis is there diagnosed, but even bone mineral density is off. You don't have any problem with it. But through the kyphosis and lordosis, yes, you see that, yes, so this looks like still osteoporosis, even with normal bone mineral density. And you have also ruled out the presence of the other metabolic causes of fractures then you can attribute the condition or the fractures to osteoporosis. What again? Again, osteoporosis is also diagnosed when the person's T-score, that is the bone mineral density, how it deviates from the average, is negative 2.5. It deviates below the mean by negative 2.5 or even more. When we are using, for example, the lumbar spine, remember we are using the axia, or if you are using the femoral neck or the hip, once you measure per the type of bone that you use, and the person is having an SD, a standard deviation, of below negative 2.5 or more, negative 2.634, that is also enough to confirm that the person is having osteoporosis, even when there is no fracture. So it means that dual energy X-ray absorptiometry measurement alone can also be used to confirm the presence of osteoporosis. What else? When the initial diagnosis of osteoporosis is made according to the T-score, that is the average of below 2.5, the diagnosis is still present even when next time you do the score and it is now even better. That is between, let's say, -1 and -2.5, because we are talking about when it is below -2.5. But if you have ever had a measurement that is below -2.5, it doesn't matter future measurements, future ones. Even if you do, probably you will be on drugs, so it can become better. Even with that, since you have ever made that measurement, it still doesn't delete the presence of osteoporosis. So osteoporosis, once diagnosed, it means that it is always there, even when you become better, unless maybe it goes above and becomes positive deviation. So that is another criteria of osteoporosis. So number one is osteoporosis is diagnosed when the person is having a fracture or fractures, repeated ones, and you have ruled out the presence of other metabolic conditions like rickets, osteomalacia, and hyperparathyroidism, those things that can also cause osteoporosis, as in fractures. Then you can attribute it to osteoporosis. If the person, you do dual energy X-ray absorptiometry, and then the bone mineral density is deviating from the mean by less than 2.5 or more, it is also another criteria for diagnosis. If somebody has ever done it and it has resulted in a lower one, even if it improves, but it's still below the average, that is, it now comes between -1 and 2.5. Once it is still not up to the level, as in the mean, or not above the mean, it is still osteoporosis. It doesn't mean that there is an improvement, so the person is no more having that problem. It is still there. So according to the guidelines, this is how osteoporosis is diagnosed. And this is how the fracture risk assessment tool looks like. It's always asking questions about the possible risk factors. So this is how almost all assessment tools are. If you are using any assessment tool, normally it includes the risk factors. And then you put everything in there, and then you do the calculation, and then it's normally automatic. It gives you the figures. So you see age is here because age is a risk factor. Sex is another risk factor. Your weight, small stature in those things, your height, previous fracture risk or previous issues with fracture. That's another risk factor. You can modify this one. The parent fracture. So family history is also there. Smoking, the use of glucocorticoids, cortisol, the presence of rheumatoid arthritis. So it is all about the presence of the possible risk factors. You can see secondary osteoporosis have ever suffered. Alcohol intake, and you are taking excessive amount, and your bone mineral density. So you input all of those things, and it will give you the calculation, and that will be compared to the mean of somebody at your age, your sex, if you're a male or female, and your ethnicity. And once it goes below the level that they need, they say that you have a high risk. So normally it gives you the percentage. So your 10 years risk of having fractures, if it's normally 20% or more, then it means that you are in trouble. You stand a high chance of getting osteoporotic fractures. Any issues? Class captain. Class captain, are you there?
Yes,
Yep.
please.
All right. There are no issues.
No, please.
All right. So now, after diagnosis, how do you do proper evaluation? After diagnosis, you've used your fracture risk, you've used your dual energy X-ray absorptiometry. Now you know that yes, there is osteoporosis, but how do you do proper evaluation? So try and evaluate all causes of secondary osteoporosis, because if they are there and they are modifiable, that should be the target. So analyze all of them and then try to modify them if they are modifiable. Then try to evaluate 4 existing vertebral fractures. So you may take some scans, maybe if the person is having fractures but not complaining any pain, though there will be pain, obviously, but should in case the person is not complaining, or even if the person complains, you need to confirm. So scans, some radiographies, x-rays, and whatever that you do to actually find out if you have vertebral fractures. Then you can also use what we call bone turnover markers. Bone turnover markers. In that, when osteoclastic activity is actively going on, you break down the bone, you expect to see more of the bone turnover markers in the blood because you are breaking the bone. If you are not having bone resorption and you are having more bone production, then you don't expect to see some of these things in high amount. So bone turnover markers like propeptide of type 1 collagen, you see, for example, if you have osteoporosis, high amount. Alkaline phosphatase, you see that enzyme will be. So we say that alkaline phosphatase is not specific. It's not only about liver issues. You also have alkaline phosphatase in high amounts within the bone, and that is an osteoblastic enzyme. If you are degrading the bone, you may see it in high amount. Then the most important matrix, the bone matrix protein, that is osteocalcin. If excessive degradation is going on, this is going to be in high amount. So elevated levels can predict more rapid rate of bone loss and higher fracture risk. You need to analyze or evaluate some of these things. Now, when do you start treatment? So indications for treatment, as in drug treatment. So in the following situations, then pharmacological treatment is highly indicated. So patients with osteopenia or low bone mass, as per the dual energy X-ray absorptiometry, you will know, and a history of fragility fracture, either of the vertebra or the hip. Such individuals, you must start them on pharmacotherapy. Low bone mineral density with fractures or history of fractures, you must put them on pharmacotherapy. Patients who have a very bad T-score when it comes to dual X-ray absorptiometry measurement, you have to put them on treatment. And even patients with relatively low T-score, that is between 1 and 2.5, they are not below 2.5. Below 2.5 is a very bad one. But even if they are better, but still below the average, and they have a fracture risk as per the fracture risk assessment too. If they have that, their chances of getting fractures within 10 years is equal to above 20%. These individuals too, you must give them pharmacotherapy. So these are the individuals in whom the guidelines say that pharmacotherapy is very important. So what are then the goals of treatment when it comes to osteoporosis? Of course, we don't want to see any fractures. So fracture risk reduction is very important. And to achieve this, you need to push the bone mineral density to acceptable limits. So we want to hit either to the average one that you expect that the person should have, or even higher, because that is the only way out. Because the main problem, one of them, is reduced bone mineral density. Of course, if it is there and there is any fractures, you also have to manage pain, because we said the pain in there is persistent, so you have to also do it. So what are the options when it comes to drug therapy? We have the so-called bisphosphonates. We can do hormone replacement therapy. Hormone replacement therapy, either you use anabolic agent or proper hormones. And at times calcitriol, which is do an unlicensed indication. So let's quickly look at these types of agents. Bisphosphonate, the various hormones, anabolic hormones, and the others, and possibly calcitriol. So bisphosphonate. What are bisphosphonates? These are analogs of pyrophosphate. And one will ask, what is pyrophosphate? So they have the pyrophosphate core structure, just that they are modified. And that confers different activity to bisphosphonate, though they have the pyrophosphate moiety. Pyrophosphate, these are normal products of metabolism, and their main work is to inhibit mineralization in blood and urine. So it means bisphosphonate rather prevents the pyrophosphate as a normal byproduct of metabolism. It is the agent that prevents mineralization within the bone and your urine, which means without pyrophosphate, you could easily have mineralization in the blood and the urine, which would cause a lot of problems. Lucky for us, we don't have this agent in the bone, because if it is in the bone, it will also cause demineralization, and that will rather give us osteoporosis. But thankfully, because of the presence of alkaline phosphatase in the bone, it degrades pyrophosphate in the bone. And for that matter, we don't get problems with pyrophosphate-induced bone demineralization, which means that individuals with any problem with alkaline phosphatase could suffer from bone mineralization from pyrophosphate, because we are saying that it is a normal byproduct of metabolism. So once metabolism is ongoing, pyrophosphate will be produced. In blood and urine, we like it. We like pyrophosphate to work there, because we don't want any mineralization in blood and urine. But in the bone, no, because if it causes, as in demineralization in there, we will be in trouble. So we will have alkaline phosphatase to deal with that. Now, what is the mechanism of bisphosphonates if it is a moiety of pyrophosphate? Why then are we using it in osteoporosis? Though the structure looks similar, but bisphosphonates do have anti-resorptive activity. And it's because they are able to block in the cells prenylation. Prenylation is just you adding or attaching as something to the C terminal of amino acid chain. So if you block this, and they also inhibit guanosine triphosphate signaling. So at the end of the day, this is the transduction, but it leads to a decrease in osteoclastic maturation. Their number is also reduced. How they are recruited to the hydroxyapatite, where you have the calcium and the phosphorus, is also reduced. Even the rate at which they can attach to bones is also reduced, and their lifespan is reduced. So bisphosphonates do have diverse mechanisms, different mechanisms which are all negative to the life of osteoclast. They decrease osteoclastic maturation. Osteoclast number, bisphosphonate will decrease it. How they are recruited to the site of degradation is impaired. How they adhere, even if they have the chance to get to where bone destruction occurs, adhesion is also reduced. And if they are supposed to stay for 10 years, we are reducing their lifespan. And therefore, bisphosphonates are very strong agents. And arguably, bisphosphonates are the mainstay when it comes to the management of almost all types of osteoporosis. Unfortunately, they can cause nausea, vomiting, diarrhea, GERD, constipation, and hypocalcemia because they are not going to allow bone resorption. If bone resorption occurs, you get some calcium back into blood. They are making sure that calcium stays within the bone, and therefore it's not surprising that they are causing hypocalcemia and some level of abdominal pain. A little bit of kinetics. Now, these agents, when it comes to absorption, is not encouraging, about 1 to 10% of their absorption. Meanwhile, this is just enough. This low level of absorption is still enough to do the work. It occurs via passive diffusion. But the problem is that if you take bisphosphonate with metals like calcium or iron, then it can inhibit bisphosphonate absorption. That means you are not going to get even that 1 to 10%, and that can affect its activity, which means that you do not have to give bisphosphonate together with meals. You have to leave a space. At least you take the drug 2 hours before you eat or 4 hours after eating. So bisphosphonate absorption is impaired with meals, especially when the meal contains heavy metals, which means it's not only meals. If you take it together with any drug that contains calcium, remember in osteoporosis, you may be doing additional calcium as in management. So you'll be giving agent that contains calcium. So mind you, you shouldn't give the two together. You need to space them. Else bisphosphonate absorption will be impaired. How are they distributed in the body? All bisphosphonates are incorporated mainly in the bone. That's a good thing because that is where we want them to be. They work in the bone, and of course, if they are distributed as high as 50% of the amount that is absorbed gets to the bone, then we are very happy. The good thing is that when they get to the bone, they are going to where they actually work, where bone resorption occurs. That is the hydroxyapatite or hydroxyapatite crystals, where you have calcium, enough calcium and phosphorus. That is where bone resorption occurs. And that is where they go and attack osteoclasts and destroy them. So we are very, very grateful as per the distribution. Now, when it comes to other tissues, negligible amount is seen in other tissues. They go into osteoclast cells and affect them. And the good thing is that after they are done with their work, they can also be released from osteoclasts and then re-enter the general circulation and even go back to the bone. So these agents are very good. They are not metabolized, and therefore you expect them to be excreted just as they go in. So it's the same parent drug that will come in, as because they are not metabolized. Neither will them also interact with any enzyme. They don't activate enzymes, they don't inhibit enzymes. They themselves are also not metabolized. And therefore, during excretion, expect to see the parent drug coming out. So they don't have metabolites. They are secreted renally. mainly by glomerular filtration. Negligible amount comes out through tubular secretion. You know ultrafiltration, you know tubular secretion, you know tubular reabsorption. So some drugs are excreted via tubular secretion, others by GFR. So these drugs are mainly excreted by EGFR, meaning that renal impairment can lead to their accumulation and possibly increase their side effects. They have a very short half-life, 30 minutes to 2 hours, then the half-life will be there. So that is bisphosphonate. We will look at the examples later as we move, when we go to the indications proper. So now let's look at some of the hormones. Hormone replacement therapy. So we have raloxifene and bezadoxifene. These are mixed estrogen. They are agonists and antagonists at the same time. So agonist, antagonist, estrogen, agonist, antagonist like raloxifene. Remember the positive effect of estrogen when it comes to osteoporosis. So can we give some of these agents for them to go and act as if they are estrogen? Try to activate estrogenic receptors and give us positive results. Now, raloxifene is a second generation mixed agonist antagonist that is approved, obviously, for postmenopausal osteoporosis. It's not surprising because in menopause, we have a problem with estrogen. The estrogen concentrations are really, really low. And therefore, if an agent that works just like estrogen is being given to treat osteoporosis, you can predict the type of osteoporosis. That is primary type 1, postmenopausal osteoporosis. The good thing is that it is an estrogen agonist when it comes to bones, but it becomes an antagonist when it comes to breast and uterus. A very good thing, very, very key. Because in bones, if we are having estrogenic effects, it is positive. We don't get bone resorption. But if it was one of those agents that can cause activation of estrogen receptors on breast and uterus, then that would give us possibly breast cancer or uterine cancer. So you don't want an agent that stimulates estrogen receptors everywhere. No, because if you stimulate estrogen receptors in several other tissues, you only cause problems with cancer. So it's a good thing that raloxifene only give us positive effect because it only acts as an agonist when it comes to the bone. When it gets to the breast and the uterus, it is acting as an antagonist. Hence the name makes estrogen agonist and antagonist. It is an agonist when it comes to the bone. You are enjoying positive benefit. But thankfully, it is an antagonist when you consider breast and uterus. So no problem with uterine cancer and then breast issues. But of course, being an estrogenic agent, it causes vasodilatation, which means it can cause flushing, it can cause hypotension and all those things. Of course, it doesn't cause endometrial bleeding because it is an antagonist around the uterus, a positive thing. But of course, as a hormone, it always predisposes to embolic problems. And therefore, almost everybody who is on estrogen therapy or estrogen like agent, it is a caution that you have to consider. And in fact, when it comes to raloxifene, it's a contraindication if somebody has a history of thromboembolic events, any of them, be it MI, be it P, be it ischemic stroke, be it DVT. Don't go and throw in the raloxifene. You increase the person's chances of getting the condition again. Another hormone that could be tried, is calcitonin. Calcitonin comes from the thyroid gland And this comes in when we have excessive calcium levels. So one of the means of getting hypercalcemia, of course, it could be from higher activity of osteoclasts. If osteoclasts are actively working, then we are getting more calcium into the blood, which will not be fine when it comes to osteoporosis. And therefore, calcitonin comes in to load back the calcium into bones. It comes in to reduce plasma calcium. How? It can increase the clearance of calcium through the renals. That is not important to us because we want the calcium back into the bone. So this is what we want from calcitonin, pushing calcium back into the bone. When it comes to a drug, we have salmon calcitonin, not just calcitonin, because this one is very potent and has a longer duration of action as compared to the human form of calcitonin. So the modified form is the one that is present as a drug. And of course, it is indicated when it comes to osteoporosis. Again, in women with at least 5 years menopause. Though we have limited data when it comes to the benefit of this agent in men, we don't have enough data on it. And also osteoporosis that is caused by glucocorticoids. And because of this, it is not yet approved, but it has the potential to do that. There is limited information on it, and therefore it is not approved. So when you are using it in osteoporosis, then it's an unlicensed indication. The pharmacology and everything shows that, yes, it can give us some benefits. But because there is limited data on it, it is still not yet approved by the authority for the management of osteoporosis. So when you use it, then it qualifies to be termed as an unlicensed use. Then the anabolic agents. Anabolic agents. So anabolic agent, basically, there are about 3 of them. One group is teriparatide and abaloperatide. These agents are having structures just like the human parathyroid hormone. So they are recombinant products that looks or derived from the parathyroid hormones. How do they work? Though they have the structure of parathyroid hormone, but they don't work like parathyroid hormone by causing osteoclastic activity. No, they don't do that. They rather do the opposite. They rather increase bone formation, bone remodeling rate, and they also help increase osteoblastic activity. How? Because if you are like parathyroid hormone, and of course you should be working like parathyroid hormone. And all the things that we've been saying is that the parathyroid hormone will increase osteoclastic activity rather, not osteoblastic activity. So why are drugs that look like parathyroid hormone now giving us the opposite? It is so because when it comes to parathyroid hormone, the immediate effect is that it works on the renal tubules to conserve calcium. That is the first effect of parathyroid hormone before eventually it will cause its problems. So these drugs has been genetically engineered to only do the initial response of parathyroid hormone, but not the eventual one that will increase osteoclastic activity. And therefore, through this mechanism, they are able to help solve osteoporosis. So that is a very good point there. By so doing, you have more calcium staying, and then more calcium goes into the bone. And of course, both bone mass and the architecture will be improved. So they don't exhibit the later effect or the later response of parathyroid hormone. That would be negative against osteoporosis. That is increasing osteoclastic activity. They only have the initial response of parathyroid hormone. That is conserving calcium. It doesn't allow the kidneys to excrete calcium, but reclaim them into the body so that they are packed into bones. Any questions? Class captain, are you there?
Yes,
Hello.
please. Um, please, I have no question. If
Okay.
any other person has a question, please look
All
at
right.
that.
Okay. So let's look at the second anabolic agent. That is romosozumab. So once you see MAB, then it is what? Monoclonal antibody. It means this drug too has been genetically engineered. Now, when it comes to bone signaling pathways that results in bone formation, if you go into details, there is a pathway called the Wengler's integrated pathway. Unfortunately, this pathway that helps in bone formation is inhibited by sclerosing, which means that sclerosing is not going to help when it comes to bone formation. It's going to inhibit the WNT pathway. Meanwhile, we want the WNT pathway to occur so that bone formation occurs. If so, then these drugs will be genetically engineered to target sclerosing. So romosozumab, for example, is targeting sclerosing. So when sclerosing is inhibited, then a WNT pathway will occur. If it occurs, we are getting bone formation, not bone resorption.